Melanoma Matters is an educational resource. The content represents our opinions and does not constitute medical advice. If you're a patient with questions specific to your situation, please consult your medical practitioner.
Hey, welcome to Melanoma Matters. I'm Sapna Patel.
And I'm James Larkin.
James, today we're going to talk about multiple triplet studies. So we thought we would kind of tackle them as a basket. Keynote 022, Combi-I, Imspire 150. These are certainly not all the triplets. We're going to hear about some more kind of sequencing and combination things at ASCO this year. But maybe before we get started, we'll do some rapid fire questions. I think at one point you asked me about my musical preferences, but I don't know if we've gotten yours. Who's your favorite band?
And when you say preferences, what do you, I don't know. Too many probably. Don't like much recent music. Actually, I think most of the decent music was made between about 1965 and 1985. That would be, that's a bit harsh, isn't it? But yeah, I honestly think that was a sort of golden era, really. I mean, obviously there has been some good stuff since, and I'm not really into classical music. There was plenty of good stuff before as well, but I like all sorts of different stuff. Probably my favorite artist is probably Bob Dylan, actually, who I haven't even had time to listen to much for a long time. I think I got as far up. I mean, I've only listened to Bob Dylan albums carefully up to about 1989, which tells you something. I haven't listened to much of his output carefully after that, but there's a lot of output to listen to. So how about that?
You like his lyrics, or you like the musicality?
Bit of both, actually. I mean, the lyrics speak for themselves, and the inconsistency in various parts of his career is also quite interesting, actually. And there's lots of albums that he's made that have been absolutely panned, but some of what people regard as his worst albums have got some of his best songs on. Actually, my favourite Bob Dylan song, that people, Every Grain of Sand. So most people won't have even heard of that, but it's on one of the early 80s religious albums, which most people dismissed. But it's a beautiful song, mainly lyrically. But anyway, that's a whole subject for a podcast, probably.
We'll send you the Tortured Poets Department anthology and measures up to Bob Dylan's writing. So related, what was the first concert that you went to?
I think Pink Floyd, weirdly, in the late 80s when I was about 15, living in Cornwall. So my friend and I drove up to London, with his dad, brought us up. And again, I think that was like the wrong time, in fact, because, I make the same comment about Pink Floyd. I think most people would agree that all the good stuff happened really in the 70s, and then by the 80s, and certainly the late 80s, it was all really tailing off. But when you're a 15-year-old, go to a Pink Floyd concert,
Well, when was The Wall? Cool. The Wall was the 80s, wasn't it?
Early 80s, yeah. But I mean, we could spend all day discussing that album, couldn't we? Because, that was all Roger Waters, basically. And, he wrote it on his own. And although, Comfortably Numb's the song everyone talks about because of Dave Gilmour's guitar playing, but actually, a lot of The Wall's quite difficult and weird and paranoid, and the film's really difficult and stuff. But anyway, I could write a book on that.
Okay, well, let's talk triplet. Where do you want to start? Which of these studies do you think is the one to jump us off?
I was going to make a general comment first, is that, the way we've done things in oncology, since the beginning, almost the speciality has been to combine drugs. It's just what we've done. And I sort of think a lot of that, the original stuff was coming out of hematological oncology and lymphoma, combining cytotoxic agents with curative intent. And we've done that with all of our other drugs as well. And I think there's several basic things here, that if you're combining drugs that are close to their single agent MTD, if you want to call it that, you're almost bound to get more side effects. And that's kind of obvious. And then the other comment, maybe we'll come back to this, is that generally it's going to be about combination versus sequence. Because actually got a patient in front of you, let's say with metastatic disease, what you should be thinking about, for me anyway, at the beginning, is what's the overall strategy? What's the plan here to do the very best to control the disease in the long term with maximum quality of life? And a lot of studies, with the best will in the world, don't answer those kinds of questions because that's just a difficult thing to do for lots of reasons we might discuss. So anyway, so that's my background statement. And then my other background statement would be the fact that there aren't necessarily loads of examples of where you can put two drugs together at close to or at the single agent doses and actually have less rather than more toxicity. And actually BRAF MEK inhibitors, the easiest example for me to think of, maybe in the whole of oncology. So this is a really special case, that how well they're tolerated together. Anyway, so for the purposes maybe of today's discussion, the question's really about, well, could you put a checkpoint inhibitor together with a BRAF MEK combination in BRAF mutant melanoma and see more efficacy with that triplet than you might with a doublet of a BRAF and MEK inhibitor? And I think that's the sort of crux of it at the moment for us in melanoma.
Yeah.
Go on.
Can I make a little maybe teaser for something we could talk about in the future? I agree with you. BRAF MEK represents one of the only combinations I can think of where the toxicity decreases with the addition of the other agent. But we recently saw some evidence in the long-term follow-up of the Columbus data that really shows that single agent BRAF is doing just as well. So then that second, efficacy-wise, is doing just as well as the combination. And then it just makes you wonder if we're really, really prescribing this expensive second agent just to help us mitigate toxicity. There should be either a better strategy or we should talk to the health ministries and say, listen, it's not an efficacy drug at this point, it's a side effect drug. Anyway, that's just something.
But well, that's quite a good point. But I wouldn't, and I don't think anyone would dismiss attempts to make toxicity more manageable out of hand. I mean, I guess the difficulty there is the context of cost. But then you might make the point in counter for these drugs that a lot of them are close to their end of their patent lives anyway. And, maybe it's pie in the sky, but if they started becoming generic, it would be less of an issue. But yeah. So anyway, so I guess the studies to talk about are Keynote 22, Combi-I, and Imspire 150. And I guess we're going to try and do that. In many ways, I think that the trials were relatively similar, maybe just to pick out Keynote 22, first of all. So randomized phase 2, BRAF mutant melanoma. And I'm looking now actually at Nature Medicine. So this is 2019, Paolo Lasciato, colleagues, Tony Ribas, senior author. 60 patients in each arm, primary endpoint progression-free survival. And then the numerical difference between the medians, basically 16 months versus 10 months, hazard ratio 0.66, p-value just under 0.05, but that was not the planned threshold for a statistically significant improvement. But I would say at this readout, really pretty encouraging in terms of efficacy. It's quite a small randomized trial. There was, to my earlier point, more toxicity, but I think broadly speaking, especially hepatotoxicity, the toxicity tended to be manageable. So I think that gave us, at least in a randomized study, the idea that there could be more efficacy for this approach. And then there's a subsequent analysis that you probably want to ask me about, which was in...
maybe to make the point, then the take is that the 16 versus 10 month difference in PFS triplet versus doublet did not meet statistical threshold significance. So technically we interpret Keynote 022 as a negative study. But I think as you're about to tell us, there was kind of a post-hoc longer follow-up reporting on this, and the story kind of changed. And if you've got the article pulled up, this is JITC 2020, Pier Francesco Ferrucci, first author, and Paolo Lasciato as this senior. In that article, I think if people are following along and you go to those curves, you see the shape of the curve changed over time, the shape of these two curves and how they separate.
Yeah, absolutely. So just to fill in the numbers there, and some of this I didn't say before. So the trial recruited between end of November 2015 and April 2017. So that's when it was done. And then in this JITSI report, basically just over 3 years of follow-up, median almost 17 months, 16.9, triplet 10.7 with doublet. And now you've got a hazard ratio of 0.53 with the confidence interval 0.34 to 0.83. And they quote some landmarks there as well. And in their conclusions, I'm just going to read it out. Substantially improved PFS, duration of response, OS, higher incidence of treatment-related AEs. But the final line, I suppose, is the killer. Interpretation of these results is limited by the post-hoc nature of this analysis. So
Which
brings up the
means,
question.
yeah,
Sorry?
which means what? How do we interpret this? They spent all of their statistical alpha in that earlier report, the Nature Medicine paper, with less median follow-up. And there it was not significant. With more follow-up, of course, more patients lost to follow-up as well and all the things. And now no statistical validity, no statistical support. This is exploratory. But in the real world, does that matter? I mean, how do you look at this longer follow-up? Does it strike you as beneficial and significant, or no, the first report was not significant?
Yeah, I mean, it's difficult to dispute there's a signal there. I mean, for me, it's as simple as that. And then you think it's a shame the trial had been analysed earlier, and if there had just been an appropriate later analysis, one imagines it would have been formally statistically positive. And this is a 120 patient trial as well. So, and again, had there been a bigger trial, one would imagine it would be clearly positive. So, I mean, I talked about this before, but I guess some of the issues there are predominantly to do with trial design, actually.
Yeah. Yeah. This is a trial design issue where they went looking too early. And I honestly can't remember what triggered this analysis. I mean, it could have been event driven. It might have been just time. But if you look at figure 1A in that JITSI paper, I mean, those curves are getting farther and farther apart over time, which really makes this point early on. Looking early on, the hazard ratio, and the p-value won't be significant, but later certainly seems to be. So I guess that maybe transitions us to the next study. You want to look at the next one, because there's a theme across all these triplets. And the theme is that the PFS seems really similar. There's some really close hazard ratios here in triplet versus doublet. Which one do you want to look at next?
Yeah. I mean, maybe just a final quick thought on this. I mean, if you're actually asking the question, does adding a checkpoint inhibitor to BRAF targeted therapy, result in incremental benefit? You're actually thinking that for the checkpoint inhibitor part of the treatment, it might be surprising if you saw a lot of it very early on, just from the drawing board in a sense. And so actually that what you're actually really looking for the patients is landmarks in any case. But again, I can't really explain all of this. So then the next one I was going to talk about is Combi-I. So this was phase 3 trial. Spartalizumab, that's an anti-PD-1 from Novartis, plus dabrafenib and trametinib versus dabrafenib and trametinib on their own. I'm just looking for the date of the paper, which it's not telling me at the moment, but I can just check that in a minute. 2022, first authors Reinhard Doomer, Dirk Schadendorf is the senior author. So again, in this trial, to your point, actually, median progression-free survival, interestingly enough, 16.2 months for the triplet versus 12 months for the doublet. Hazard ratio 0.82, and the p-value there, I should say with confidence intervals overlapping 1, so 0.66 to 1.03, p-value 0.042, not significant. Objective response rate, maybe this is of interest as well, 69 versus 64%, so not an enormous increment there. And just to say something about grade 3 or worse treatment-related adverse events, 55%. versus 33%. So this trial didn't hit its primary endpoint. But
make a couple
again,
of comments
go on.
Good, Ben. Yeah, so I think primary was PFS here. Is that right? Yeah, investigator assessed PFS. And this p-value, interesting to me, I mean, they report a one-sided, so you double it to get a two-sided p-value. And so their one-sided is 0.042, so that makes their two-sided 0.084. You can populate in the knots there, however you want to say that. But so that is interesting that they, the numbers are striking very similar to that Keynote 022 PFS of 16 months. This is what I take away from all these triplets, is they're all supporting each other, at least in terms of what the median PFS is in that triplet arm. But the toxicity is real and undeniable.
Yeah, that's right. And what I hadn't said, and I'll just say now for completeness, is just to give an idea of the number of patients. It's about 265 or so in each arm for Combi-I. So it's about 530 patients altogether. So for phase 3 studies, you'd probably say slightly on the smaller side, but nevertheless a decent number of patients being randomized in the study. And the study, as a consequence of what we just said, being formally labeled as a negative study. Which I guess brings us on to the Imspire 150 study. And again, a sort of very similar type of study design, BRAF mutant melanoma, atezolizumab, vemurafenib, cobimetinib, that's the triplet, versus vem-cobi as the doublet. I'm actually looking now at the Lancet paper from the beginning of January 23. Paolo Ascierto is the first author, Ralph Gutzma actually is the senior author, where actually they reported OS, and actually the trial was negative for OS. But if you go back to the first report of the paper, this is now the Lancet 2020, and Ralph Gutzma is the lead author. For PFS, again, similar sorts of numbers, around about 260 in each group, 19 odd months of follow-up. And again, to your point, 15.1 versus 10.6 months for the median PFS, increase in toxicity, which we don't need to labour too much. But then that's ended up on the right side of the line. In terms of positive versus negative, but actually that hazard ratio for these two trials was 0.04 apart. So again, putting it together with Keynote 22, there's a signal in there. And actually, had things been done slightly differently, in a way, both of these trials could be quote unquote negative, or in a way they could be both quote unquote positive, and one's positive, one's negative, which I guess speaks to the inadequacy of the labels. But listen, anyway, so what I need to ask you, obviously, so vem-cobi atezo's got a label, FDA label in the US, BRAF mutant, advanced BRAF mutant melanoma. Sparta Dabtram doesn't. No label for vem-cobi atezo, I don't think, anywhere ex-US. Are you prescribing it in your clinic? Have you ever prescribed it in your clinic? And what would be the sort of patient, where this would be the right treatment, do you think?
So you're going to make me justify a little bit of my clinical practice here, which I'm sort of happy to do, I guess. So the short answer is yes, I've prescribed it. My takeaway was that you showed us, you described it to us and we were familiar when it was being presented and publicly available, a phase 2 and then 2 phase 3s that all comfortably told me this was not a fluke effect. Side note, I think from the US office, a fluke is the most common fish in the sea, one of the most common fish in the sea. So that's probably the wrong use of the word, but it's not by accident that there's a signal here. These 3 studies with 3 different BRAF MEK PD-1s are telling us there is an enhanced effect when you add single agent PD-1 to BRAF MEK. Okay. So then I started thinking, is there a treatment I can give a BRAF positive patient? And all of this obviously came out before we knew DreamSeq data. But is there a treatment I can give them that gives them this frontline progression-free survival? We could argue Ipi-Nivo is the treatment that would do that, right? And it would give you a nice long progression-free survival, particularly in the BRAF positive population. But, you know, maybe I'll use your own words that you said to me earlier, which is, you're thinking about the strategy for your BRAF positive patient. And the strategy, it has to include BRAF MEK targeted therapy. Because if you think about a BRAF patient in front of you and only think about immune checkpoint inhibitors, it is hopeful, but you can't forget that you need to expose them to BRAF MEK at some point if they don't get cured with their checkpoint inhibitor alone. So I guess all that said, my strategy was, well, I've got this BRAF patient. Why should I have to choose between this or this? Let me use checkpoint and BRAF MEK targeted therapy. And over BRAF MEK targeted therapy alone, I'm getting an enhanced progression-free survival. This is more than you get with BRAF MEK in the frontline setting. All of these control arms are giving us a 10, 12 month. The, BRIM studies told us it was, or not the BRIM studies, sorry, the Combi studies had told us these were all about 9 months anyway, with BRAF MEK targeted. So is there a therapy I can give a BRAF MEK patient that gets them 15, 16 months with the first and second treatments sequenced together? In other words, if I use BRAF MEK, I get to 9, 10, 12 months. Is what I do next going to get them an additional 4, 5, 6 to get us to 15, 16? Or am I getting the maximal benefit now? We don't fully, truly know that answer, but I felt like there was some potential here. And then, of course, the Keynote 022 long-term follow-up makes you really feel that there is a signal over BRAF MEK alone. Now, that said, would I rather use quadruple therapy than triple? We'll hear about, some of this in the near future. So I used it. So I used the triple Vemcobi Atezo in a couple of cutaneous melanoma patients frontline. I used it true to kind of form. And now I have a plea for the investigators and authors of that study, because I think this most recent publication that you were mentioning, the Imspire 150, this Lancet paper talks about a final analysis that's awaited, because this was a second interim analysis. This final analysis is awaited. In that final analysis, one of the things I need to see, because it's made me a little gun shy of the triple, is I need to see about incidence of brain mets. And if we're using triple, are we staving off brain mets? Are we just, because of use of BRAF MEK, pushing to a sanctuary site? What exactly is happening? Because I certainly had the experience in a few of the early patients that I treated, maybe treated 3 or 4 within the first year or 2 of approval, that they looked to be appropriate candidates. And then while the disease was controlled, by the way, there's a run in here of Vemcobi, which is, it's okay. And then the dose drops a little bit when it's combined, so it doesn't smash all full doses together. Nevertheless, there's toxicity. I saw these patients developing brain mets. And I had to really question whether that was the natural biology, whether the intervention was really making that sooner than I, was comfortable seeing. But yeah, I would like to see about the incidence of brain mets in the control arm versus the triple arm here when they do their final analysis. So not just OS, PFS stuff, but also tell me about brain mets. That's going to help me really decide, how to use this. I think in general in the US, though, you're not seeing a lot of this prescribed. And there's 2 reasons in my mind. 3. One is this BRAF MEK inhibitor is amongst the hardest combination to tolerate. It's a really high pill count. The vemurafenib alone at full dose is a really high pill count. These are uncoated large tablets, as opposed to capsules for some of the other BRAF agents. So this BRAF MEK combination also the idea that you're using kind of all of your active therapy agents up front, and for the toxicity it's engendering, are we sure that you're getting are we sure it's worth it to not just sequence this? And I sort of led with all of that. We don't know, but there's some feeling that maybe you could break these regimens apart. And then I think the third reason is it's lacking the most active agent we use in the frontline setting, which is combination immunotherapy. And so for, I think those reasons, the US uptake, if you looked at claims data, or if we were to ask, the pharmaceutical company here, Genentech, I think you'd see there's not a whole lot of use in the US. Do you think if you had approval in the UK, there'd be use of this triplet?
No, I don't think so. I mean, for the reasons that you say, I mean, one of the arguments people make might be that you've got someone who's absolutely in crisis, and you do see that sometimes, and you really need to sort of do everything in that situation, treat them with everything up front. But I mean, I think we have DreamSeek now, and that's going to be a nice segue into that because we need to talk about that separately. But honestly, even before, and I think we've probably talked about this before, actually, even before we had the DreamSeek data, I would be treating those patients with Ipi/Nivo and just watching them very carefully. And if I was worried they're progressing, I'd treat them with Zabtram. And for me, that's the kind of standard of care, I think I would say. I think we've talked about this before. You've got kind of like more relaxed reimbursement, shall we say. So I guess you have the opportunity to treat people with targeted therapy in that situation to start off with. And then the question is about switching into Ipi/Nivo, especially if you're kind of waiting a long time to get them in an infusion chair, right?
Yeah. And then potentially bouncing them back to BRAF targeted. So Secombit, DreamSeek, this is all a natural future episode we can have, a couple of episodes. I think that visceral crisis patient is the one that you see in studies like DreamSeek that causes, they don't overtly tell you the patient's in visceral crisis, but you can almost pick it out from the demographics of that study. And then Secombit sort of gives you comfort. Well, what if you led all patients with BRAF targeted therapy, even the ones not in visceral crisis? So should you lead with that and switch early versus switching at progression? I think this is all a natural discussion, but the interesting things that will be emerging are there's the EBIN study, which is Oncobini switching to Ipi/Nivo, I think inverse. There's also studies looking at, there was the TACO trial that was presented at ESMO 2023. This was atezolizumab, bevacizumab, MEK inhibitor. So it's just a different triplet. There's also the triplet that's being used in the SWOG S2000 brain met study, which is BRAF MEK PD-1 there, and that's Oncobini PD-1. And then you could imagine there might be some folks, particularly with the long-term Columbus data, where encorafenib alone seems to have as much efficacy as encorafenib and binimetinib, but obviously tolerability is better with combination, where you might want to do doublet immunotherapy and maybe a single targeted. But I think the toxicity is what's limiting so much of this anyway, because in the real world, what I can tell you is happening is certainly you're taking all these drug holidays because of toxicity. Well, then what is that really doing to efficacy at that point? So anyway, what else should we say about triple therapy, do you think?
Well, I mean, the summary is that I think we can agree pretty clearly there's a signal there, but for various different reasons, they haven't all read out positive. And then even the trial that has read out positive, despite regulatory approval, is not getting widespread use. I was just going to make another general point, actually. I mean, with BRAF mutant melanoma and Ipi/Nivo, for me, it's a great thing if you can just give checkpoint inhibitor therapy and then the patient never needs to have any more treatment. You put them on targeted therapy, and honestly, you're basically committing the patient then to being on that therapy with some level of chronic side effects. Everybody's got some level of chronic side effects for quite a long period of time, and obviously not everyone's going to get benefit from Ipi/Nivo or any checkpoint inhibitor therapy, but the possibility of just being able to deliver that therapy and then have salvage with targeted therapy, I think is really powerful, because we know that there'll be some patients, who are in that scenario, never need to have targeted therapy. So that's my final thought, I suppose.
Yeah, I mean, let me build on that though. DreamSeek is going to tell us that, and DreamSeek had restrictions that we don't have in the real world, which is you will quickly switch to targeted therapy if you see somebody's not benefiting. DreamSeek required a kind of confirmation that they're not benefiting. So it delayed the transition over to BRAF MEK. And then many of those patients, actually none of the patients who were progressing on Ipi-Nivo made it to BRAF MEK. So we all agree it's a tragedy. We've probably said it here before. It's a tragedy when a BRAF positive patient doesn't touch BRAF MEK inhibitors. But that could happen. If you start with checkpoint blockade, you could miss a window to give somebody BRAF targeted therapy. So it begs the question, do you have any hints or do you see any signal of who are the BRAF positive patients where Ipi-Nivo is enough? What are the clinical factors that you see, or do you see any sort of biomarkers in the blood or in the tumor?
No, I mean, I don't, at the moment, beyond what we've discussed in the past, I don't really have a great feeling for this at all. I mean, we have a few fairly crude biomarkers still, but I don't really think we've got anything that's particularly usable, honestly. The other interesting, go on.
Should you and I treat some of these patients, collect their BRAF ctDNA, collect it at 4 weeks? Some of the David Polsky ctDNA data on the Combi studies, the BRAF studies in metastatic disease, showed a 4-week time point clearance to be somewhat predictive. Should we be looking for clearance there to be predictive of the patients who might be cured? It still doesn't tell you from the beginning who to treat, but it maybe tells you, I don't know. I guess I don't know. I don't know. What do you?
No, I mean, I don't know the answer to that either. The other thing that this is just a footnote as well. I'm not sure there are loads of data. This is purely anecdotal, but I've had quite a lot of patients over the years who treated with Ipi-Nivo and they've just progressed straight through, usually with bad tempo, high kinetics, high burden, high LDH disease, all that sort of stuff, sometimes including brain mets as well. When I put them onto brafenib and trametinib afterwards, this is obviously all outside trials, anticipating a level of benefit for the dabrafenib and trametinib of whatever, 6-9 months, not more. And they're still in my clinic over 5 years later, still on dabrafenib. I've got lots of patients like that, actually. And you might say, well, maybe I'm over-treating them now. That's a whole separate discussion as well. We could maybe have another time.
But you bring up the point that the inverse is true, that there's a group of patients in whom can you identify where the checkpoint won't do it, and you will need to be moving them to targeted? I mean, this is the real question when you have a frontline BRAF metastatic patient in front of you. It's how do I know?
Yeah, or could this be a really late response to the checkpoint inhibitor treatment that they've already had because they were in such bad shape at the start in terms of immune fitness that they probably couldn't get benefit? This is what I wonder about. But actually, then you give them the targeted therapy, you make them feel a lot better afterwards. You've got the checkpoint inhibitor still on board by definition, given the half-lives and everything else. Then they begin to develop a benefit. But it's a really striking thing. Now we've been giving these treatments for a long time. I've got all these patients in my clinic years later. And the things I'm now worrying about is, and they will ask me, can we stop treatment? What do you do? How do we monitor for side effects? All this stuff. That's actually a subject of a discussion in its own right, because I think we're already at 33 minutes.
Yeah, this is a long one for people. This is a long workout if somebody's listening at the gym.
No, 33 minutes isn't a long workout. Go on, carry on.
Come on. Depends on the intensity. As opposed to listening to 2 of ours, as if anybody would do that. So like in these group of patients that you have long-term BRAF MEK after they had checkpoint, it would be interesting to know when they got the checkpoint, was it not just a lack of benefit to the checkpoint, but also you didn't have to touch steroids or immune suppression. So you gave them this cloud of T cells. T cells weren't able to do anything. And once you gave the BRAF inhibitor, because we know the BRAF oncogene is immune suppressive, once you took away that immune suppressive force field, now this cloud of T cells could move. It would be interesting. I think it would be a different potential narrative if they didn't do well with checkpoint and you had to give them immune suppression. So now you essentially don't have that quantity of T cells around. But it would be interesting to know if that was your experience, because then that on its own might be just some clinical thing to pick out. You've got somebody, they're not doing well, but then, the early transition over to BRAF MEK while checkpoint's still in the system.
Yeah, and I enjoyed the clouds and force fields as well. So that's like, the image.
All right. Well, thanks for taking us through triplet studies. This is an important area in the field, and we're not using it in clinical practice, I guess, is the takeaway. One of these studies is positive, 2 were negative. 1 has regulatory approval in the US, but still the uptake is not that great. So that tells us as a field, we still have a lot more questions to answer for how to kind of combine and sequence these treatments. Yeah.
Okay, thanks.
Okay. All right. Thanks. Stop. They're probably